know how it's starting out. Okay, good to know. Hey everyone, my name is Cooke. I'm a PGY1 resident here at UMC, and today I'm going to be talking about cytomegalovirus infection in immunoprominent pregnant patients. Right now at UMC I'm on a women's health rotation in Weiser, and we have a patient right now that is infected at 18 weeks gestation with cytomegalovirus, and she is immunocompetent. So a little bit more introduction to my patient case. She presented at 18 weeks in July with jaundice, hemolytic anemia, and transaminitis. And she presented with this complaint of yellow eyes and brown urine following a 2-month stay in Mexico. She's otherwise healthy, and we basically just did a round of any kind of study we could think of that could be causing this hemolytic anemia. We did things like a bone marrow biopsy. We tested for any type of hepatitis, toxoplasma, leptospirosis, acute fever, you name it, we tested for it. And nothing came back positive except for a positive CMV IgM, a positive CMV IgG, and a CMV DNA PCR of 3,400 copies per milliliter. So a little bit of an overview of cytomegalovirus. It is a double-stranded DNA herpes virus. And just like any other herpes virus, it causes this primary infection, and then it goes late. And it can be reactivated at any time during life. 50 to 80% of the adult population is infected with CMV, and it is transmitted through body fluids. So in immunocompetent patients, usually if you see a patient who's infected with this, it just produces this mononucleosis type of syndrome. So it's not very serious. It sometimes can even be asymptomatic. But in immunocompromised patients, so our HIV patients, transplant patients, it can actually be pretty life-threatening. But single organ and multi-organ infections in immunocompetent patients has happened before, and it can produce complications with any of the organ systems I've listed. Something that pertains to our patient is considered hemolytic anemia. We also consider hepatitis in her. So to diagnose CMV, we do several blood tests. One thing we do is serology, or test for the antibodies against CMV. If someone comes back with a positive CMV IgG, it means that they were infected with CMV at some point in time. That doesn't mean that they have an active infection now. However, if they have a positive IgM, it means that they've either been newly infected, they were infected in the past but have been recently exposed to CMV again, or they're undergoing a reactivation of that latent virus. We can also do a quantitative PCR, which just gives us that viral load. Our patient actually started out with a viral load of 700, and then over the next week, she increased to about 3,400 copies per mil. We can also do a tissue biopsy, and CMV-infected cells have this very unique look to them. They have a very large inclusion body, and it looks like owl eyes. And that gives the virus its name, cytomegalo, or large cell. We decided against doing a tissue biopsy in our patient. They considered doing a liver biopsy in her just because she was having this jaundice and these liver issues. But we decided not to do that for her because she's pregnant. So the risk definitely outweighed the benefit for a definitive diagnosis of CMV. So to diagnose a CMV infection in pregnancy, there are 2 types of infections in a pregnant patient. Primary, meaning that she was infected during her pregnancy, or non-primary, meaning that she was infected before she conceived, and then she now has antibodies against the virus. Infants that are born to mothers with a primary CMV infection have a lot of serious adverse effects related to them. If you're infected in the first half, you have a transplacental infection risk, so CMV does cross the placenta. The risk is about 40%, and about 10% of those babies will have those symptoms when they are born. But about 90% are asymptomatic. However, if you get CMV during the second half of your pregnancy, the risk of transplacental infection is about 75 to 85%. But those babies having serious complications, the risk is very low. In other words, you would rather be infected in the second half of pregnancy. So congenital CMV is the most common congenital infection, infecting about 1 in 150 children. There are several complications that are associated with it, including hearing loss, vision loss, mental disabilities. And when you're talking about a fetus, the risk to a fetus is very serious. It can cause uterine growth restriction. It can cause ventriculomegaly. It can cause just a lot of problems for a child or for a fetus. So to diagnose congenital CMV, we can do a viral culture or a PCR of the amniotic fluid, but the risks of amniocentesis are very high. So we decided against doing that for our patient as well. Or you can diagnose it after delivery as well, and that's between 2 and 3 weeks after the child is born. So to treat CMV in adult patients, we have several antiviral agents that are active. However, none of these agents are indicated for immunocompetent patients. All of these antivirals are listed are only for immunocompromised patients. So we had to do something, right? So I'll talk about a couple of these drugs, anciclovir and valganciclovir. These drugs are pretty much the same. Valcite is the prodrug for anciclovir, to keep the world burden. Its mechanism is a nucleoside analog that inhibits viral DNA synthesis. It's only FDA approved for, again, immunocompromised patients with CMV retinitis or CMV transplant prophylaxis. The dose, it's got an induction and a maintenance dose listed, and some adverse effects include anemia and neutropenia. And for this patient, we did not want something like that because she's already got this hemolytic anemia. We don't want to make it worse. So we chose against doing with those for her. And then the pregnancy risk associated with these, they're both pregnancy category C. Valcite actually doesn't have a pregnancy category associated with it. I don't know if you guys have heard that the FDA has changed the labeling for all drugs in July of this year. So now drugs will no longer have pregnancy categories associated with them. And the company has decided to go ahead and update this drug so it no longer has a pregnancy category associated with it. So again, anciclovir pregnancy category C, and it does have a box warning for teratogenicity and then impairment of fertility. The next drug is foscarnet. This is a pure phosphate analog that acts as a non-competitive inhibitor of viral DNA polymerase. It is indicated for CMV retinitis as well as an acyclovir-resistant HSV infection, herpes simplex virus. Its dose, it has an induction and maintenance phase. And then its adverse reactions include renal toxicity as well as mineral and electrolyte abnormalities. These electrolyte abnormalities include things like hypomagnesemia, hypocalcemia, hypokalemia, pretty much anything you can think of, it probably causes it, and that particular patient had just about everything. And then it also causes seizures that are associated with the electrolyte abnormalities. And then cidofovir, the last antiviral agent, it incorporates into a growing viral DNA chain, and it inhibits viral DNA polymerase. It is FDA approved for CMV retinitis. It again has an induction and a maintenance phase. Something about this drug, it causes an acute renal failure. So whenever we treat someone with this drug, we always do saline hydration. We also do a probenecid, which protects the kidneys. And then we have another adverse reaction, which is again neutropenia. The pregnancy category risk is C. It does have another box warning for teratogenicity and inhibition of fertility. Another drug we can use is cytogam, which is an IVIG directed against CMV in particular. This is just a high concentration of CMV antibodies. It's used for prophylaxis in solid organ transplants, and depending on the transplant type, that's the kind of dose that you give. Adverse reactions are usually things like flushing, chills, muscle cramps. And then the pregnancy risk is a C, but there are no animal or human studies for pregnant patients, so in other words, we don't really know, so why don't we just give it a category C? I think that's why they're getting rid of the pregnancy categories. Okay, so something else I want to talk about along with treatment. It's important to counsel mothers, especially because many pregnant women have other young children at home, and CMV is transmitted a lot in daycare centers. Approximately 80% of children in daycare centers will get CMV within 2 years. So just some things to help pregnant patients from getting CMV, especially if they don't have CMV already, as they can just avoid just sharing body fluids with children. Don't share utensils, food, don't kiss them on the mouth or the cheek, and just wash your hands. Pretty much typical things to prevent infection. So wrap up on our patient case. So our patient's viral load wasn't very high. I don't know much about CMV, but I know that when it comes to a lab value, our lab value reads up to 25,000. So when it comes to the range, our patient's viral load wasn't very high, but because she was pregnant, we had to treat her. We didn't want this patient to get any worse, and clinically, she was not improving. So we gave her a dose of cytogam, 20,000 milligrams IV, one dose, and she will be getting a monthly infusion until she delivers. We also decided on foscarnet due to the lowest pregnancy risk, and we gave her 60 mg per kg IV every 8 hours. She requires constant electrolyte replacement right now, and the plan is to continue that induction therapy for 2 weeks and then start maintenance dosing until her CMV PCR has disappeared. This patient finished foscarnet yesterday, and we decided not to start a maintenance dose on her. This is just not on the paper, it's nothing. So the thing with this patient is because she's pregnant, the team decided that when we're dealing with an unknown drug and we don't know how it's going to affect her child in the future, we decided to just go ahead and discontinue it. Her CMV PCR has reached less than the value that the lab can read, so we decided against treating this patient, and she has improved clinically. And then when it comes to her fetus, so imaging shows that there is no risk to this fetus right now. We again decided against an amniocentesis because the risks associated with amniocentesis are just too hard. We can diagnose this child once they deliver. And also, if the child doesn't have CMV now, there still is a risk of getting CMV once she delivers. If any blood is shared between the child and the mother, there is that risk. So it really wouldn't even matter if we know that the child has it for sure. The risk is just too great for an amniocentesis. And then fetal heart tones are being monitored daily, and baby's doing good. So, does anybody have any questions about this patient or about CMV and an immunocompetent patient? When it comes to immunocompromised, that's not really what I know about. But any questions?
Was the drug dependency aspects of the medications we drove to?
Yes, so I'll go into that more. So when it came to choosing a drug, there were several things that the team decided against. So when it came to ganciclovir and valganciclovir, several things drew them away from that drug. First of all was the box warning for teratogenicity. But the second thing was the anemias and neutropenias that are associated with it. This patient's primary problem was her hemolytic anemia. And that was giving her a lot of the jaundice and the other complications that she was having. So that's why we decided against those. And when it came to cidofovir, the same thing. It had that box warning, so that's why we went with foscarnet, just because it was the least of all of them. So yeah, that's what drove us to foscarnet.
Emily, not really the lead focus of your presentation you mentioned.
Sure, I can tell you anything about
the pregnancy warnings.
Yeah.
You talked about how there was a transition. Can you give the group a little feedback on why the decision was made by the FDA?
Yes, so I actually wrote a newsletter article about this. So the next pharmacy newsletter there's an article written by me about the pregnancy categories. So the FDA saw that the pregnancy categories, there's been a lot of, I guess, things against those pregnancy categories for years. Everyone thinks that, well, if it's one category C drug must mean that it's the same thing as another category C. Amy and I were actually talking about the pregnancy category X drugs, for example. So everyone knows what Accutane does, right? It's got these huge teratogenic effects. But things like statins are also category X, but the data is not near the same as what is seen with Accutane. So that's just one example. That doesn't mean that statins have the same exact effects as Accutane. So because of that, because the drugs are not equal in the class, and well, if it has no data, so we're just going to give cytogamma C because there's no data on it. I mean, I just don't agree with that at all. So they're going to, they're going to take away the categories completely. Any new drug after July of this year will have no category. Any drug approved before that has to comply with that rule within the next 3 years. And then what they're going to do is they're going to add these sections. So they're actually adjusting the sections of the package insert. It's going to be a pregnancy category. There's going to be a lactation category, and then there's also going to be a fertility category for males and females. And it's just going to give basically it's going to show a risk summary, and then it's going to have a section for data that shows the actual studies of what happens with the different.
Question then. What happens to older drugs that may not have a drug listing that's actually updated?
I don't know about those. I just know that any package insert that's out there has to be updated in the next 3 years. Now, I'm not sure about any other drugs.
I don't know the exact point, but there is a date, like a package insert that's out there that was brought to market, like sometime in the early 90s.
2001 for sure.
Will be voluntarily asked to do that, but there will be some that won't do it.
Yeah.
They have different dates. It's actually a really complicated schedule, but everything will be phased in gradually within the next 3 years. Thank you.